Today's ID Rapid Review focuses on the SCORPIO Post-Exposure Prophylaxis trial published in the New England Journal of Medicine, evaluating Ensitrelvir as oral post-exposure prophylaxis for COVID-19 among household contacts. We will also draw heavily from Dr. Paul Sachs's accompanying New England Journal Voices commentary, which frames the clinical relevance of this trial very clearly. More than 6 years into the COVID era, we may finally have an oral preventive strategy after exposure that actually works. The key question is straightforward. After a household exposure to symptomatic COVID-19, can a short course of an oral antiviral prevent symptomatic infection? Until now, for COVID-19, the answer has been no. This study suggests that Ensitrelvir may change that. COVID-19 is no longer the same disease it was in 2020, but it has not disappeared. It continues to impose a substantial burden, particularly among older adults and those with medical comorbidities. One of the persistent challenges is household transmission. During the Omicron era, reported household secondary attack rates have been as high as 32 to 48%. The analogy is influenza. For influenza, we have long had antiviral post-exposure prophylaxis options, such as oseltamivir or baloxavir. But for COVID-19, prior post-exposure prophylaxis trials with nirmatrelvir, ritonavir, and molnupiravir did not show significant protection. Ensitrelvir is an oral inhibitor of the SARS-CoV-2 3C-like protease. It is in the same broad antiviral target space as nirmatrelvir. In Japan, Ensitrelvir is approved for treatment of mild to moderate COVID-19, and based on this trial, for post-exposure prophylaxis in contacts 12 years or older. The goal is simple: do not get infected, do not get sick, do not miss work, and most importantly, do not transmit to a vulnerable household member. SCORPIO Post-Exposure Prophylaxis was a Phase 3, double-blind, randomized, placebo-controlled trial conducted from June 2023 through mid-September 2024. The trial enrolled household contacts of a symptomatic index patient with documented COVID-19, with the contact randomized within 72 hours of symptom onset in the index patient. The index patient could receive antiviral treatment at discretion, but the intervention was directed at the household contact. Household contacts were eligible if they were at least 12 years old, had a negative antigen or PCR test, and were asymptomatic. They had to be enrolled within 72 hours after symptom onset in the index patient. The primary modified intention to treat population included those who were RT-PCR negative at baseline and received at least one dose. Key exclusions included recent infection or vaccination, pregnancy, and persons receiving contraindicated medications due to drug interaction potential. Participants were randomized to receive 5 days of Ensitrelvir or a matching placebo with the first dose directly observed. This was a virologically intensive study with serial nasopharyngeal swabs through day 28. The primary endpoint was laboratory-confirmed COVID-19 within 10 days, requiring both RT-PCR positivity and symptoms lasting at least 48 hours. It's not merely a positive PCR, but clinically meaningful symptomatic COVID-19 confirmed virologically. A total of 2,387 household contacts underwent randomization across the global study sites. The mean age was about 42 years, and 37% had at least one risk factor for severe COVID-19. Crucially, more than 98% were seropositive. This was COVID prevention in the modern, highly immune era. The primary result was striking. Symptomatic COVID-19, by day 10, occurred in 2.9% of Ensitrelvir recipients versus 9.0% with placebo. The risk ratio was 0.33, corresponding to a 67% relative risk reduction with a 95% confidence interval from 51 to 78% relative risk reduction. In absolute terms, the number needed to treat to prevent one case of symptomatic COVID-19 was approximately 16. The cumulative incidence curves show that the protective effect was established early and maintained through follow-up. Placebo event rates were much higher in Japan, possibly due to higher index patient viral loads compared to the United States. Ensitrelvir also appeared to reduce infection itself, showing a 34% reduction in RT-PCR positivity regardless of symptoms. So why did this trial succeed where others failed? Earlier initiation, within 72 hours, may have been a critical factor. As Dr. Sachs notes, preventing infection is better than treating it, avoiding missed work, canceled travel, and spread to vulnerable family members. The safety profile was reassuring, with adverse event rates similar between groups and no serious drug-related events. The main laboratory finding was a reversible decline in HDL cholesterol that approached baseline by day 15, with no changes in median triglyceride concentrations. Genome sequencing identified some treatment-emergent protease substitutions, though they did not appear to drive prophylaxis failures. A major limitation was exclusion of many patients at risk for severe COVID, such as those with a health condition requiring systemic corticosteroids. Additional limitations include the need for early testing and rapid access, the household-only enrollment setting, limited data in nursing homes, hospitals, immunocompromised patients, unknown cost and access, and important drug-drug interaction, such as statins, considerations because Ensitrelvir is a moderately strong CYP3A inhibitor. Ensitrelvir fills a specific gap: short-course oral prophylaxis for household contacts with at least one risk factor for severe illness after early recognized exposure. Bottom line, SCORPIO post-exposure prophylaxis provides the first convincing evidence for an effective oral antiviral post-exposure prophylaxis strategy for COVID-19. In the COVID therapeutic saga, this is a combination we have not had before.